Welcome everyone to the first video of the ECG crash course, where we'll go through a basic systematic approach to interpreting ECGs. So we'll firstly quickly recap the conduction system of the heart. So electrical activity starts at the sinoatrial node, and this sends a signal down to the atria, and this depolarizes both the right and left atrium, forming our P wave. That signal will then eventually reach the atrioventricular node, which will hold on to that action potential, creating a physiological delay, and that will be seen on the ECG as a PR interval, which is measured from the beginning of the P wave and the start of the QRS complex, which is this big spike here. That signal will then go down the His bundle system, down each respective bundle branch, and the specific bundle branches that you need to know is that this is called the left bundle branch, and this is called the right bundle branch, and that depolarizes the ventricles, forming our QRS wave, or QRS complex, which is that big spike. Then the ventricles will repolarize, forming our T wave. We don't get to appreciate atrial repolarization because it's quite a small signal, and it's likely buried somewhere within the QRS, so we can't see it on a surface ECG. One thing to note is that we have specific intervals that we should be aware of. So we should know how to measure the QRS width. If I get a different pen out. So the QRS width is measured from the beginning of the Q wave to the end of the S wave. And that should be no bigger than 3 small boxes. If it's bigger than 3 small boxes, we call that a bundle branch block, which we'll look into later. We also should be aware of our ST segment, which is measured from the end of the QRS complex to this here. So this is our ST segment. I think I've just drawn a bit over there. If I can rub that out. So that becomes important when assessing, when looking at myocardial ischemia, which will be looked at in a different video. Another interval to be aware of, which will become more important when we consider ventricular arrhythmias, again explored in a different video, is something called the QT interval, which is measured from the start of the Q wave to the end of the T wave, just there. So that's our QT interval, and that should be ideally no greater than 440 milliseconds in men and 460 milliseconds in women. And then this last wave that we have here, which we don't typically see in patients, but in this case it's shown in this ECG. This last bibble, this last little bump, is called a U wave, and this is associated with a finding in hypokalemia. Again, this will be explored in a separate video. So that's the basic ECG waveforms that you should be aware of. Another thing that you should be aware of is that each grid on the ECG, each small grid on the ECG, when measuring across, is worth 0.04 seconds or 40 milliseconds. So one big box, which is 5 of these small boxes together, is representative of 200 milliseconds or 2 seconds across, or 0.2 seconds across, sorry. Another thing to know is that each square is also a millimeter, each large box is 5 millimeters across, so each small box is a millimeter big, And that becomes important when measuring the amplitude of the QRS. So each small box is a millimeter big, so each large box is 5 millimeters. That's just something to be aware of. And that's related to the standard calibration of an ECG. So let's analyze an ECG step by step. So how would you systematically approach the analysis of an ECG? So I think I'll stick to my purple pen. So firstly, we want to make sure that we've got the right patient. So we would look at their ID, date of birth, name, all of that stuff. In this case, this is anonymized for good reasons. Then we'll check the calibration of the ECG. So the calibration of the ECG is checked here. And what you want to make sure is that the electrical voltage should be it should be 1 millivolt for 10 millimeters. So we already said that one box was 1 millimeter, so 10 of them will be 10 boxes here. And that's representative of 1 millivolt. And that's what this little square represents. And that means you can accurately measure the amplitudes, which we'll look at later on in the video. We also want to check the the paper speed of the ECG, which should be set at 25 millimeters per second. So if you see 25 millimeters per second, that's the standard calibration for analyzing ECGs. If this was 50 millimeters per second, that means that the paper speed is too fast, and so your ECG will become stretched out. So it can sometimes look like the heart rate's going slower when actually in fact it's just that the paper speed isn't the standard setting. You also want to look at one other thing, which is the amount of filter that's been applied to the ECG. And the standard filter settings is between 0.05 and 150 Hertz. So just make sure that the filter setting is set on correctly. And the reason why that's important is because if we filter out too much signal, it means that we basically essentially mask some important ECG findings. So let's systematically analyze this ECG. So after all of that, we can now jump into the actual waveform and what's going on. So the first thing you want to confirm in an ECG is whether you have normal sinus rhythm. So is the sinoatrial node the one that's setting off the electrical conduction? And the easiest way to find that out is look for a P wave. So here's a P wave here, here's a P wave here, and this is the same P wave because a ECG, you look at it going across. Anything that's above or below on an ECG is the same point in time, if that makes sense. So this is one beat, this would be another beat, this would be the next beat, and so on and so forth. So in some leads, you may not see clear waveforms, and that's why you look at all the leads in an ECG to gain a general assessment. So after identifying a P wave, we can be confident this is sinus rhythm, it's not atrial fibrillation. If you don't know what atrial fibrillation is, check out the supraventricular arrhythmia video where we go into more detail into what that is. But essentially in atrial fibrillation, you won't see a P wave. And then after identifying a P wave, you want to identify, is there a QRS that follows it? And in this case, we see a nice QRS here. And then you want to make sure that the QRS isn't particularly broad. So we mentioned earlier that a broad QRS is anything greater than 3 big boxes. This doesn't look 3 small boxes. This doesn't look bigger than 3 small boxes. So this is a normal QRS. It's less than 120 milliseconds. And then we just make sure that that there's a T wave following it. So we can already say from this ECG that it's sinus rhythm. Then we'll go on to measure the rate of the ECG. So to measure the rate, you want to find 2 clear R waves. So in this case, you want to find them usually, the most easiest way to work out rate is to look for 2 R waves that are on basically lines you can see. So in this case, you can see that this R wave lies on this grey line here, and this R wave lies on this grey line here. So the R to R interval is this area here, and essentially you count the number of small boxes. So I can say there's 5, 10, 15, 20, 25. So there's 25 small boxes. I know that each small box is worth 0.04 seconds. So I just grab a calculator, type 25 times by 0.94. So I know that each R to R interval is 1 second. 1 second. And then all I need to do to work out the heart rate is work out how many R to R intervals are in 60 seconds, because we do beats per minute. So you do 60 divided by 1, which is, well, 60. So we know that this heart rate here on this ECG is 60 beats per minute. And obviously, we just look at the ECG machine and it says it's 62, which is roughly what we got. So that's the easiest way to work out heart rate. So now we've worked out rate. So we have sinus rhythm. We know the rate is at 60 beats per minute. Anything below 60 beats per minute would be classified as a bradycardia. Anything above 100 beats per minute would be classified as a tachycardia. In this case, it's neither tachy or brady. And then we look at the ST segments and check if they're normal. ST segments will go through more in depth within the STEMI and NSTEMI videos, so keep your eyes peeled for that. But in this case, we can see the STs look normal in these leads here. They look normal here. They're slightly flat here, which is fine. And then they look slightly strange in our precordial leads here. So there's some slight takeoff here. There's some slight high takeoff here. Again, that's explored in a different video. But then they look normal here. But for the most case, looking at the context of the patient being a young patient, this is likely not to be an ACS. This is likely just high takeoff. So this would be sinus rhythm going at a rate of 60 beats per minute with some evidence of high takeoff in our precordial leads. That's how you analyze an ECG. Then you can find additional things, something called cardiac axis, which we'll look at now. So what is cardiac axis? So cardiac axis sounds like something really complex. It's not. It's basically just working out the overall vector of where the electrical signals are going in the heart. So as this diagram nicely represents, generally the average movement of electricity in the heart should go towards the left ventricle, because the left ventricle is the biggest muscle in the heart. So that's where electrical activity should generally go. This diagram here is the basis for working out cardiac axis. You just have to memorize it in your head. But essentially, how we work out axis is we look at the lead where electricity basically averagely goes to. So we can see here that the normal cardiac axis lies between -30 and 90. Anything more negative than -30, so between -30 and -90 is left axis deviation. Anything between 90 and 180 is right axis deviation, and then anything above that in this strange zone is called extreme axis deviation. So generally, in most healthy patients, the axis should go towards here. It should be between -30 and 90. So how do we work that out? So we first look at our lead 1. This is lead 1 here, because we know it's one of our lateral leads that lie here. And it should be positive because the signals are going towards this lead, so the signal should be positive. Likewise, in lead 2, that's also assessing the left ventricle. That should also be positive because electricity is going towards it on an average vector. And then if we look at AVF, that's just about in the walls of the left ventricle too. And signal should also be going towards it too. So it should also be positive. So that's how you assess for a normal axis. And it's not really complicated at all. So what does it look like if you have a abnormal axis? Well, let's work it out for this ECG here. So we'll get out our handy dandy cardiac axis finder. So we'll look at leads 1. So leads 1 are positive, so we know that electricity is going somewhere roughly here in this zone here. I'll rub that out actually. So we know roughly that electricity must be going somewhere here. So now looking at leads 2. Leads 2, the amplitude's slightly a bit smaller, so electricity might be going a bit there, but not too greatly. So the electricity is probably still mostly going towards here. And if we look at AVF to confirm that, we can see AVF's completely negative. So we know that electricity is not really going down there, because otherwise we'd see a positive QRS. So let's look at AVL now. Well, AVL strangely is positive. So an average amount of electricity is actually going somewhere around about here. So that's sort of pushing our electricity into the left axis deviation zone. And if we look at lead 3 as well, we can see that's completely negative. So we know that electricity isn't really going towards this side at all, really, on an average basis. So we can say that this is likely has a level of left axis deviation. So if I draw that in there, so we say that the axis lies somewhere between -90 and -30, which is left axis deviation. So a cheeky way to work out left axis deviation is looking at leads 1 and leads 3 and quickly eyeballing it. If the QRS complexes are pointing away from each other, so this lead 1 is pointing upwards, and leads 2 you can see the S wave is pointing downwards, and you can see that they're pulling apart from each other. We say that they've left each other, and so we say that's left axis deviation. That's just a quick eyeball way of working it out. It works for like 90% of ECGs. For the other 10%, you have to go out and work it out yourself. So let's work out the axis for this ECG. Again, let's grab our handy dandy axis machine. So let's look at leads 1. So leads 1 are predominantly negative this time, so we know that electricity isn't really going here. So let's look at leads 3. So we can see in leads 3 that it's positive predominantly this time, so we know that electricity on an average vector is going somewhere between 90 and 180 degrees. So we can already start to think this might be a right axis deviation. If we now look at leads 2, we can see they're predominantly negative too, so we know that electricity isn't really going here. And you can see AVR is even positive as well. So the electricity is sort of meandering towards here. So I'd say that the axis is somewhere around about here. So this is a right axis deviation. And if you're to look at AVF, it's biphasic in this sense. So it's neither going towards AVF nor going away from it. So it's probably somewhere around about here. So this is a right axis deviation. And again, an easy way to eyeball right axis deviation is look at the leads 1 and leads 3 again and just draw out where the QRSs are predominantly pointing towards. So this in lead 1 is predominantly pointing downwards, and this in lead 3 is predominantly pointing upwards. We can see that here. And if the QRS complexes are pointing towards each other, we say they are right for each other. So we say that's right axis deviation. So that's just again, works for 90% of cases. There might be that 10% of cases where you have to actually work out the axis manually. So right and left axis are associated with, they can be physiological in some cases, especially left axis deviation, and they can sometimes be associated with certain pathology. So in the case of right axis deviation, it might be associated with right ventricular hypertrophy, where the right ventricular wall has started to become enlarged, and that's why more of the electricity is going towards it. It can also be associated with certain respiratory pathology as well, because that's all involving the right side of the heart. So let's dissect the QRS further. So we mentioned earlier, when a QRS is broad, we classify broadness as anything greater than 120 milliseconds, which is greater than 3 small boxes. And we call that finding a bundle branch block. So what is a bundle branch block? So it's an issue at the level of the His-Purkinje system. So somewhere here, the conduction system's gone a bit dodgy. And you can either have a right bundle branch block where electricity refuses to go down the right bundle, likely because it's diseased and become old and rubbish. Or you can have a left bundle branch block where instead of the right bundle being diseased and damaged, it's actually the left bundle that's gone a bit dodgy. And electricity won't go that way. So this causes a delay in depolarization because depending on the bundle branch you have, the bundle branch block you have, electricity has to divert on a super long pathway. So if, for example, in this case, if the right bundle was blocked, electricity can perfectly go down the left bundle. So it will depolarize the left ventricle first, and then that electricity goes down a really long convoluted pathway to the right ventricle in order to depolarize it. And that creates a specific waveform. But because that takes so long, that's what creates that broadness. And the opposite would occur if you had a right bundle branch block, a left bundle branch block. Electricity would need to find its way back to the left ventricle in a really long way. So what are these distinct QRS morphological changes that you see with specific bundle branch blocks? So we'll go through right bundle branch block first. So firstly, if you're going to assess a right bundle branch block morphology, every QRS in the ECG will be broad, but to find out the specific pattern that you're dealing with, look at leads V1 or V2. Right bundle branch block is either described as an RSR pattern, an RR pattern, or an RSR pattern. There's many different descriptions for it. However, I'll teach you a cheeky way to work it out. So these are the different morphologies you have, but there's one thing in common that connects all these morphologies together, and it's this thing called bunny ears. So you see bunny ears within each of these bundle branches. So if you look here, this is like a small bunny ear, and then this is a big bunny ear. And if you're to use your imagination, you can see that it kind of is a bunny rabbit. This is my poor drawing of a bunny rabbit. But you can see here, these are like little ears. And it doesn't matter, don't worry about this RSR rubbish. Just as long as you can see bunny ears, you'll be safe. And you can see here, these are bunny ears that look more sort of the same shape. So that's the secret to recognizing a right bundle branch block, is this bunny ear thing. You'll hear things like William Marrow. That's a bunch of rubbish as far as I'm concerned. Bunny ears are the way to go forward with right bundle branch block. But if William Marrow works for you, go for it. So how do you recognize left bundle branch block? So left bundle branch block, when you see it enough times, it's smack bang in your face. But basically, again, you look at V1 and you'll see this RS pattern. And I've made R a little r because the R wave is this first spike here, and it is just really small. See the R wave there as well? And then I've made the S a capital S because the S wave, which is this massive thing here, is really big. You can see this massive deep S wave, and even in this lead it's even more huger. So a left bundle branch block always has a small R wave, but it has a huge gonging S wave, and that's in V1. And always look at V1, and that's how you recognize left bundle branch block. Again, people talk about William Marrow. It's a load of rubbish. You'll see left bundle branch block, and you'll never need to think about William Marrow ever again by just using this recognition. Exactly, you can't miss it. This S wave is so deep, you can't miss it. So please be aware that ST segments and T waves look weird in bundle branch blocks, so interpret them with caution and in light of the patient's symptoms. And why I say this in this video is because in my later videos you'll learn about STEMIs and NSTEMIs, which are ECG findings for myocardial ischemia and myocardial infarction, and they're associated with ST segment changes. But ST changes occur in bundle branches, and so it becomes difficult to make a diagnosis of a STEMI and NSTEMI in a left bundle branch block. So I always say analyze it in with patient symptoms, because if a patient is coming in with chest pain, it kind of puts you at more sort of suspicion that it's actually an ACS that you're dealing with, rather than it being just normal. So now we'll look at the QRS voltage, which I talked about earlier with the calibration and all of that stuff. So QRS voltage is an important part of ECG interpretation to look at. With experience, you'll know what a normal QRS voltage looks like by just eyeballing it, and when the QRS voltage looks abnormal, it's quite smack bang in your face. So it gives you an underlying idea if there's ventricular hypertrophy, and again it relates to that axis as well. It can cause axis shift and all that stuff, ventricular hypertrophy. There's various different methods of assessing QRS voltage. The one that I tend to use is Sokolov line criteria, which basically involves looking at the S wave in V1, that thing that we talked about earlier, and looking at the R wave in either V5 and V6. So the S wave, remember, is the deep, is the downward QRS part, and the R wave is the upward stroke. And you look at the S wave in V1 and the R wave in either V5 or V6, it's your choice, and you basically measure the amplitudes of each of those parts. So you'd measure the amplitude here and the amplitude there, and you combine them together. And if it's greater than 35 millimeters, that's suggestive that there might be some left ventricular hypertrophy. So we'll use this example here. Let me first rub out these lines. So if we work out this one together, we can see the deep S wave in V1. So if we were to measure that from the isoelectric baseline here and measure downwards, we can see that's around about 5, 10, 15, at around about 14 there. So let's say that's roughly 14 millimeters downwards this S wave is. And we make sure it's calibrated to the 1 millivolt equals 10 millimeters. And then we look at our R wave, which is this upward spike here in V5 or V6, and we can already see that this R wave is huge because we can't even see the end of it. So let's go for the biggest one here. So we can see that's roughly there, but we could even measure that one there. But essentially, if we look at this one, for example, because we can actually see the ending of it, so let's draw the isoelectric baseline there. We can measure this as roughly 4, so that's 5, 10, 15, 20, add on the 4, so that's 24, actually there's a bit more there, so that's about 26 or 27 millimeters there. If you punch that in a calculator, I'm sure that's 40 millimeters amplitude combined, and that's greater than the 35 millimeters that we needed to diagnose a left ventricular hypertrophy. And that's how you work it out. But you can already see that this is a huge R wave here, so you can visually work out that's a left ventricular hypertrophy. And left ventricular hypertrophy in this case has actually created some form of like left bundle branch block pattern as well. So you could say in this ECG that you see a sinus rhythm with a left bundle branch block with findings suggestive of a LV hypertrophy in this case. So let's dissect the P wave further. So the P wave should normally look like a hump. So it should look like a hill. And in leads 2, in most leads, and in V1 you can sometimes see a biphasic pattern, and that's completely normal. That's what you should see in V1, and you should see a sort of a hill looking pattern everywhere else, and this is normal. That's what a normal P wave looks like. Sometimes the P wave can look weird, and in this case the P wave has a taller amplitude, a bigger amplitude here at the beginning and then a smaller amplitude at the start, and this is suggestive. And then it has, in the biphasic part, there's like a massive spike at the start, and this is basically representative of right atrial enlargement. So the right atrium here where the sinoatrial node is, has basically stretched and become bigger. And then that means that it takes longer for the right atrium to depolarize, and it takes longer for that signal to get to the left atrium, which is why you see this slightly bigger spike, and then it's followed by the representation of the left atrium then depolarizing slightly later. So that's right atrial enlargement. If there's right atrial enlargement, this one must be, by a process of elimination, left atrial enlargement, when you see this sort of classical M-looking shape. You see this sort of M-looking shape. By the way, a right atrial enlargement finding is called P. pulmonale. And you can remember P. pulmonale because the pulmonary, how I remember it is that the pulmonary means lung, like the lung system, and you know that the right atrium is the right side of the heart, and pulmonary and the right side of the heart are similar, so P. pulmonale is the way I remember it. So that's just the specific name for right atrial enlargement. This M shape is suggestive of left atrial enlargement, which is called P. mitrale, which you can remember because it looks like an M, but also the left atrium. So in this case, the left atrium has become bigger, and the left atrium is attached to, or the mitral valve attaches next to the left atrium, mitrale, P. mitrale, so left system, and it also looks like an M. So the reason why it looks like an M is because you have the right atrium depolarizing first, so pretend that's not big. You have the right atrium depolarizing first, which is represented by the first bibble, or the first bump. And then because the left atrium has now become huge, that action potential has to then travel further to depolarize the left atrium, which is why you get this secondary bump, a secondary prominent bump in leads 2. And that's what creates that M shape, or that P. mitrale shape. And then this last part is basically if you see coexisting right atrial enlargement and left atrial enlargement together, you would see a big initial spike and then followed by the classic M shape. So that's dissecting the P wave. So let's do some practice now. So feel free to pause the video, work out the ECG yourself, and then I'll pop up the answer and then we'll go through it together. So answer's popping up in 3, 2, 1, 0. So this is sinus rhythm with a right bundle branch block, and it's going at a rate of 100 beats per minute with a normal cardiac axis. Well done if you got that right. If not, we can go through it together. So why is it sinus rhythm? Well, we don't see any clear P waves in this lead. We can kind of see a P wave there, However, if we can't see it clearly in these leads, let's look at the other leads. We can see our precordial leads, we can see a clear P wave there, we can see a clear P wave there. So we know this is sinus rhythm, and we can even see a clear P wave there as well. So we can see P waves in other leads, so we know this is sinus rhythm. We then look at our QRS. So look at the QRS. Is it particularly broad? Well, if we look at our precordial leads, we can definitely see that they're broad there. If we were to measure from there to there, we can see that that's greater than 3 small boxes. I appreciate the ECG is not the most clearest in the world, but you can see that's definitely broad there. And if you're to measure it from like here to there, you can even see in that lead it looks broad as well. I know it looks like a funny shape again, but that means that there's a underlying bundle branch block. So now you need to work out what bundle branch it is. And we can see, if we look at leads V1 or V2, we can see, what can we see? We can see bunny ears. Yay! So this is right bundle branch block, the R standing for rabbit, or in this case, the right bundle not working properly. So, and then if you were to work out the R to R interval, you'd get, and times it by 0.04. If you'd work out the R to R interval and do 60 divided by the R to R interval, you'd get 100 beats per minute, which is at borderline nearly sinus tachy. And then if you were to work out the axis, you'd get normal axis. So we'll get our trusty cardiac axis out again. We can see lead 1 is positive, so we know that the electrical signal is somewhere around about here. we can see lead 2 is positive, so we know that the electrical signal is still within here. Leads AVF is it's slightly positive, it's slightly small, but it is positive. So we know that the electrical axis is still somewhere within here, and AVL is positive, so it is trying to go through there, but because all of these leads are positive, we know that the axis must be somewhere around about here, so we can say it's normal axis. So our next example, feel free to pause the video, work it out. There's the answers coming up in 3, 2, 1, 0. So this is sinus rhythm with P mitrale with a normal axis and a rate of 75 beats per minute. So well done if you got that right. If not, let's work it out now. So why is it sinus rhythm? Well, easily we can see P waves here, P waves there, followed by QRS. The T wave is a bit flat here, but we know there's a T wave because if we look at other leads, we can see the T wave clearly. So we know this is sinus rhythm. So look at the QRS. Is it particularly broad? Not really. It measures around about just within 3 small boxes, so we know there's no underlying bundle branch block. So we don't need to comment on that. So then we work out the axis, which we pop up our handy dandy axis. We look at the leads 1, which are positive, so we know it's somewhere in the normal axis range. Look at leads 2, which is also positive, so we know it's somewhere here. Look at AVF, they're positive, so we know it's somewhere between this definitely, so we know that's a normal cardiac axis. Hooray! And then if you were to work out the RTI interval and divide 60 over the RTI interval, you'd get 75 beats per minute, which we know that's normal, a normal heart rate. So where's the P mitrale? Well, if you look at lead 2, you can see an M shape. So there's your P mitrale, and you can see an M shape even in lead 3 as well. So there we go. So P mitrale, which is suggestive of left atrial enlargement, because M mitral valve is on the left side, the left atrium. So well done if you got that right. If not, just carry on practicing, and trust me, you'll get amazing. So that's the end of the video. Thank you for listening. I hope you found it useful, and feel free to check out my other ECG videos, and I'll catch you in the next one.